A 5-year-old male child, Master ABC, coming from Iruvelpattu, who is brought by his mother, who is an informant, and the reliability is good, came with chief complaints of not attained age-appropriate milestone since 1 year. Since the insult starts from the early period of life, I would like to start from the birth history, sir. Birth history, he is a first-order child born out of non-consanguineous marriage. Antenatal history, conceived at the age of 22, spontaneous conception. Weight gained in the pregnancy is 12 kg. And periconceptional folic acid was not taken. Registered an antenatal she registered her pregnancy in a nearby PHC. A number of antenatal visits 6. First trimester, the pregnancy was confirmed by UPT after 2 weeks of missed periods and first dose of TD taken at that time itself. And there was a history of fever for 10 days, which was not associated with rashes. She took paracetamol for it and no other medication was taken. There is no history of maternal hypothyroidism and folic acid tablets was taken and dating scan was done at 10 weeks. In the second trimester, quickening felt at 20 weeks and all other were normal, sir. Can I proceed to the third trimester?
Yes, very good, very good.
And third trimesters too, she was able to appreciate the fetal movements well, and growth scan was taken. It was at 33 weeks and it was normal, and there is no history suggestive of gestational diabetes mellitus or PAH, and no history of maternal infections, and no history of PROM. And labor, it was a full-term vaginal delivery. There was no instrumentation and there was no delay in delivery after rupture of membranes. The liquor was clear and no fever before or after delivery. Neonatal history. The birth weight is 2.9 kg. The baby did not cry immediately after birth. Resuscitation was done and the details about the resuscitation was not known by the mother, and the baby was admitted to the NICU for 3 days for the same reason, and there was no history of convulsions during the NICU admission or in the neonatal period, and the Apgar score was not known by the mother, and she didn't bring the details too, and the time of voiding urine and passage of meconium not known, and no meconium stained liquid. Breastfeeding was started after 3 hours of delivery. And coming to developmental history, the child attained neck holding only at 1 year and roll over by 6 months and sits with support at 8 months and without support at 2 years. The child is now only able to stand with support, which was attained at 3 years, and stand without support is not attained by the child. So the developmental quotient in gross motor domain is 15%. In fine motor, the unidextrous reach was attained at 7 months and bidextrous at 1.5 years, and immature pincer grafts at 3 years. And the mature pincer graft is not attained by the child. So the developmental quotient is 15%. And coming to language domain, the child has not attained 8 to 10 words, 10 words speaking with meaning, and child is only able to speak 1 to 2 words with meaning like mama, papa, like that. And the developmental quotient is 20%. And in social and adaptive domain, the child attained social smile by 4 months, and the child is recognized mother at 3 months, and the child smiles at mirror image by 8 months, and waving bye-bye was attained at 3 years, and the child is plays simple ball game by 3 years, and the child is now able to ask for food and also indicate toileting, sir. The developmental quotient is 40%. So coming to history of presenting illness, the child was apparently normal before 1 year, after which the mother noticed that the child has not attained the age-appropriate milestones. The child didn't attain neck holding even after 1 year. The mother... The mother compared the child growth with a neighbor child of the same age and found her baby was not attained the milestones. Only after 1.5 years, the child attained the neck holding. So she went to the nearby hospital where the child was diagnosed as a case of global developmental delay and was referred to the higher center. The mother didn't bring the previous records with her in this visit. She said the child was given physiotherapy and speech therapy, but they continued the treatment only up to 3 years of age, after which they discontinued the treatment due to some other reason. The child was able to recognize mother, which was attained at 3 months. There was history of difficulty in holding baby, and there was history of inconsolable cry occasionally, and there was history of stiffness in all 4 limbs, and history of difficulty in getting up from bed, and history of difficulty in taking objects from height, and history of difficulty in mixing foods, and there was a history of spillage of water and food while taking it to the mouth, and history of difficulty in changing diapers. And mother noticed that the crawling of the child was abnormal. The child was able to crawl at 2.5 years of age, and the child was able to perceive touch and able to appreciate the pain. If it feels if it's siblings or someone hurts the child responds by crying, and the child is able to appreciate the hot water poured over him during bath, and he is able to appreciate the cold temperature also, according to the history from the mother. And there was history of difficulty in breastfeeding in the early childhood period, and there was history of contractions in legs, and the child had history of recurrent respiratory tract infection. There was no history of regression of attained milestone, no history of convulsions, no history of fever, and no history of emotional disturbances or aggressive behavior. Sir, can I skip through, or I have to read that, sir?
Yeah, very good. Go ahead. Complete your history if you have
Years were
anything.
normal, sir, and there was no early hand preference like that, and the bowel and bladder movements were regular, and the child is dry by day by 4 years of age, and there was no history of trauma to head and no history of frequent falls. Coming to immunization history, the child was immunized appropriate for the age. And past history, the child is a known case of global developmental delay diagnosed at the age of 2 years. And treatment history, the child was undergoing treatment, physiotherapy and speech therapy for the same. And in the diet history, the child was exclusively breastfed for 6 months, and the complementary feeding was started at after 6 months, and the breastfeeding was continued till 1 year of age, and the calorie deficit was only 17.5%, and protein intake was adequate. And coming to family history, there is no history of similar illness in any other members, and no history of convulsions, and no history of inborn errors of metabolism. And socioeconomic history, they belong to lower middle class, and they come from an urban area. There was no overcrowding. They lived in a well ventilated house, and waste was disposed in street bins, and history of rodents present, sir. And contact history, no history of contact with a known case of TB. So coming
very
to
good. So don't summarize. In fact, stop sharing slides for a while, and let's all of us have a video on so that we can discuss with each other. Okay. So let all participants put on your videos so that we can see each other and also discuss in person rather than hidingly. So would everybody put on their videos? Very good. Madhumitha, would you put on your video?
Sir, if it's tracking, sir, I don't know what happens.
Okay, doesn't matter. Now, I think you gave a wonderful history. I just want to fine tune everything that you said, but it was very good and in details. My first question to you would be, you started saying that the child was brought for the delayed development, but you would like to start from birth. Now, what made you decide to start from birth? You get my point? Here is the mother who comes and tells you that her child is apparently not developing well since the age of 1 year. Now, how do you suddenly guess that the problem has been since birth? Would somebody give a thought?
Sir, I would.
Yeah, go ahead.
The mother brought the child at 1 year, sir, but I would like to start from the birth, so that if there are any risk factors or any a problem which occurred during the antenatal or in the 1 year of age, sir.
Very good.
So I
So
thought,
what you could have done is you should start your history saying that the mother brought this child with delayed development noticed since 1 year of age. However, child was not well even prior to that. That's a statement. See, many
okay, sir.
times the students start history saying that the child was apparently well 1 year ago. No, we don't want apparently well. We want it really well. So you should always say that this mother came with a complaint of delayed development noticed since 1 year of age. However, on direct questioning, the child was not normal even before that, and therefore I start with a birth history, right? So
Yes, sir.
that is important. So, so once you go further on that, you have given detailed history of how that thing. Now, my question to you is that apparently there was something that went wrong at birth because the child did not cry at birth. So, what do you understand when child doesn't cry at birth? Anyone, feel free
The
to
birth asphyxia.
birth asphyxia. So, what are the symptoms of birth asphyxia? Okay, you are right that one of the causes of a child not crying at birth could be birth asphyxia. But just because child, for I'll give you an example. Child may not cry at birth because the mother was heavily sedated just prior to delivery, and the baby had an effect of sedation. So baby did not cry. The baby was normal, right? Another issue is that not every baby must cry at birth, though almost all babies cry at birth. But that's not a single point to go by. Occasional normal baby may not even cry at birth. So, not crying at birth, yes, is abnormal, but we need to look little more in details. So now tell me, what are the symptoms of birth asphyxia at birth? Yeah, anyone, give a thought, doesn't matter. See, you seem to know so well, you are presented so well. So we are just going to discuss and learn by discussion. So what happens to birth asphyxia?
That's,
Yeah, go ahead, go ahead.
the child didn't cry, sir, and the child did not respond to the tactile stimulation. Would not have been respond to the tactile stimulation given, and
The cyanosis, sir.
sinus.
Cyanosis, all right. Now,
The heart
let
rate
me
would
tell
be
you.
lesser.
Very good. I
And
think as an undergraduate, you are doing extremely well. But let me tell you correctly what birth asphyxia really means. Birth asphyxia means the neonatal behavior is not normal because the brain is involved. So neonatal behavior has to be abnormal. Now that puts up a question, what is the neonatal behavior? I'm sure as fourth year student, you must have attended few deliveries and seeing normal babies delivered at birth. So how does a baby behave at birth? Would anybody try to answer this?
The
That's a
child.
neonatal. Yes, go ahead. Go ahead, Avantika.
so a loud explosive cry, a good effortive cry, a good muscle tone, which means the baby tries to squirm around. Then the baby also has good color, is pink.
Very
Then
good.
um, upon checking, the heart rate and the blood pressure is also adequate for that gestational.
Very good. Excellent. Now, my question was neonatal behavior.
Right, right, right.
You gave all the points on examination as well. Very good. But what is the behavior? A child cries lustily, tries to latch on the breast when put on the breast. That's the tone and posture was normal. Okay.
Yes, sir.
Most important is awake for 20 to 30 minutes and then goes to sleep
Right, sir.
and wakes up after 3 4 hours, and the cycle of feeding and sleeping starts. So the most important part of neonatal behavior is cries lustily at birth, gets onto the mother's breast, sucks vigorously, is awake, and that is the period which is used for bonding with the mother. And then nature has allowed the baby to remain awake for 20 minutes just to meet the baby's mother, whom the baby has never seen. Can you imagine the urge of meeting? One author has put it so well, and if you listen to this, you will understand what nature has done. This author describes the baby's wakeful state and bonding as similar to tomorrow. Suppose after your MBBS and post graduation, you decide to go abroad for further studies, and you are going to return after a year for a small vacation. Entire your family will go to the airport to receive you. Okay, they are eager to meet you. They are all waiting outside, looking through the window panes while you are clearing the customs and the luggage. And when you come out, they hug you. And then after 20 minutes, they say, oh, it's middle of the night. You must be tired. Let's go to sleep and then carry on next day. What a perfect situation. This baby is inside for 9 months. Mother has not seen the baby. Baby has not seen the mother. They are all eager to meet each other. So immediate bonding for 20 minutes, followed by a very long travel. So tiredness and sleep, and then carry on life. Wonderful simile. That's what the neonatal behavior is. What is the point to learn? Suppose this baby cried immediately at birth, but never stopped crying. That's abnormal. This baby cried immediately at birth, but never remained awake and fell off to sleep. That is not normal. So, neonatal encephalopathy, which means the brain is damaged, is known better by the neonatal behavior. And of course, each point you said on examination is very, very valid, but many times you may have to depend on the history and you are not there to examine. So now knowing this, tell me whether this baby suffered any problem at birth, birth asphyxia. I'll give you a clue. You gave the history that at 3 hours the baby was put on breasts.
Sir.
That means the baby was so well in 3 hours time, which meant that there was no significant birth asphyxia. There could have been small point here and there. There could have been some secretions in the airway. The baby was not breathing well. Baby required a little tactile stimulation. Maybe sometimes a bag and mask, a little oxygenation. But in the event of all that, the baby could be put on the breast at hour 3, indicates that there has been no significant birth asphyxia. You get the point? Just
Yes,
because the baby did not cry does not mean that the brain is damaged. This is important. Though something subtle change might have occurred, but it was not significant, right? The next point is the baby was discharged in a week's time. Am I right, Madhumitha?
Sir?
Baby was discharged in a week's time, right?
Yes, sir.
Yeah. So now if this baby could be put on the breast on hour 3 and could be discharged at the end of a week, we could almost feel that there was no significant birth asphyxia. That's the point to make. So ultimately, we may not blame whatever delay in development to birth asphyxia because we have no clinical evidence on the history of any birth asphyxia, right? So good. So far so good. We have come out to say that there may not be a significant birth asphyxia. Now, as you gave the milestones so well, and I'm impressed by your domains percentages. Okay, but something struck me. One is that this baby started holding head and neck at 1 year,
Yes, sir.
but could roll over by 6 months. Am I right?
Yes, sir.
Now, what do you mean by that? I'll give you a clue. Generally, the development proceeds in a systematic way.
It's a cephalocaudal and proximal to distal, sir.
Excellent, excellent. Then why this sequence was changed? Any idea? See what
Maybe
I'm trying to.
atypical.
Yeah, come on, come on.
So that means like it was a atypical development, not the normal development is not followed.
Agreed, but I want to know what makes this atypical development make the child roll over reasonably on time or a bit late, but the head holding has yet not come and is so much delayed. So point to make is the head must be large and difficult to hold head. When, when the head is large, the child can roll over before holding head. We take a note of that, not necessarily. See,
Okay, sir.
the beauty of history has been taken so much in details. I think I congratulate you for that. But the next thing is pick up anything that looks odd and start thinking what must have happened. The first thing that we said was there was no significant birth asphyxia. The next thing we are saying is the head may be large. We are not sure. But see, the beauty of history taking and analysis is 80-85% of diagnosis must come from the history alone. And history may tell you what examination findings you expect. That's the beauty of taking history. So we have now said that is another thing. Very good. Now, Madhumitha, you have said that all domains are delayed, but there is a disproportionate delay. What do you make out of that? Your social adaptive is 40%. Your language is 20%, but your motor milestones are 15%. What is the inference of such a differential global development?
So maybe the family support may be good so that the child has social and adaptive skills and language better than the other two, sir.
All
And they
right,
didn't.
good. So what you mean by that really is that the motor milestones are more involved than the social adaptive and language.
Yes, sir.
So what do we make out of that? We must have a definite abnormal signs in the motor system. And we can have many more things. But the motor system is definitely involved. Now, so we have now concluded birth asphyxia was not significant, head was large, and motor system is involved. Now, who can guess whether it was an upper motor neuron or a lower motor neuron? Only
Sir,
on the history. Yeah, go ahead.
that stiffness. There was stiffness in all four limbs, and there was a feeding difficulty in the early childhood when the mother gave the child breastfeeding. So it may be human, sir.
Very good. So it must be UMN. Now tell me, can it be basal ganglia which also has stiffness?
No, sir.
Why? Basal ganglia also has stiffness, extrapyramidal system.
Right.
You know that both pyramidal and extrapyramidal system have stiffness. So what do you think about? Yes, go ahead.
Athetoid and dyskinetic movements would predominate in basal ganglia.
Excellent. So basal ganglia have abnormal movements and abnormal posture.
Yes, sir.
Okay, we haven't got that history. So this must be a UMN. How wonderful we are locating anatomy only by history. So we have a UMN, right? Now, when we discuss diagnosis, we go systematically. We first arrive at an anatomical diagnosis. And not only anatomical, microanatomical. So now tell me, the system involved is CNS, right?
Yes, sir.
Now, could it be a peripheral nervous system?
No, sir, because there was a diffuse.
Well,
All
peripheral.
the 4 limbs were
Some
affected, sir.
peripheral.
Well, I may have a severe lower motor neuron lesion affecting all the limbs. So that's not the reason. Give better reason.
So there would be hypotonia in case of
Excellent, excellent.
uh,
So contractures and stiffness suggest that it is coming from up there. So okay, now we know that it's not only central nervous system, but even spinal cord can have an upper motor neuron, right?
Yes.
Yes.
Yes,
So
sir.
now tell me whether it is spinal cord or something intracranial.
So spinal cord would be a tract involvement, so it would just be on one side, unless it's a complete transaction.
Excellent, excellent. But suppose now I give you transverse myelitis, then what happens?
That would be a more progressive involvement.
And that will be localized to
localized
a
to
lesion
particular
below.
segment.
Okay. And even if it's cervical, then at the site of lesion and below the lesion, there will be difference.
Yes,
So
sir.
now we have come to a conclusion that this must be intracranial, upper motor neuron.
Yes,
Okay. Now
Yes,
tell
sir.
me, intracranial upper motor neuron goes from cortex to subcortical, internal capsule, then midbrain, down there, right up to pons. Where is this lesion? Only on the history. You get my question. Now we are localizing upper motor neuron lesion.
So area number 6, bed cells of the motor cortex in the parietal lobe. Because,
All right. Why do you say that? Why do
so-
you say that?
Because according to the history, it seems to be a quadriplegia, and both the sides are involved. So I wouldn't expect just one.
Excellent, excellent. So it has been a diffuse lesion, and lower down, it could be accompanied with many cranial nerves involvement.
Cranial nerves, right, sir?
Subcortical would have had some abnormal movements. Okay. Internal capsule on one side could have had a hemiparesis. So your point is right that diffuse cortical lesion without cranial nerve involvement. So now your anatomy is cortical motor system. Excellent. All right. So we have now defined microanatomy, right? Only on the history. So our history suggests that possibly there are no other sites of lesions intracranially because there is nothing, no abnormal movements, you said, no cranial nerves. So now we have a diffuse bilateral motor cortex involved. Sensory system is normal, you said. So sensory cortex is not involved. Those tracts are not involved. Excellent. Cerebellum is not involved. Yes, go ahead.
According to the history, there was some history of regurgitation of food, coughing. Could that be a cranial nerve, like a 9th and 10th cranial nerve
If
involvement?
it was due to cranial nerves, it could be one change in voice,
Right, sir.
drooling. So possibly this is an incoordination. See, motor system has incoordination.
Correct.
Okay.
Yes.
So this must be a part of incoordination, and almost many children who are developmentally delayed tend to have a swallowing incoordination. And the result is the recurrent respiratory infection. That's what you said.
Yes.
So possibly, but good question. Okay, so now we know that anatomy is bilateral motor cortex. Now come to pathology. To guess pathology in the history, let me repeat what I said in my last session also, that you recall few pathological conditions that you have learned. Inflammation, degeneration, demyelination, infiltration, infarction, atrophy, hypertrophy. Okay,
Yes, sir.
which one is this?
Atrophy, sir.
Atrophy, all right, good. So it could be atrophy, we don't know, but it's certainly not an inflammation.
Yes,
Okay.
sir.
Degeneration is a slow progressive worsening of function. So at this point of time, Madhumita, tell us whether this problem is static or progressive.
Sir, it's non-progressive, sir. It's
Why do you say that? Why do you say that?
sir, the milestones was not progressive, but the orthopedic problem like contractions were progressing. So the child, at increasing age, the child had difficulty in develop contractures, sir.
Very good. But give me a better definition of a progressive disorder as against non-progressive disorder. Yes, anyone?
Sir, in progressive, there will be loss of milestones which are attained.
Yes, but loss of milestones is a definite history of progression. But even a progressive disease attains some new milestones, but much slowly. Okay. So point I'm making is a, a static lesion and a progressive lesion refers to static DQ, developmental quotient, and a progressively worsening DQ. I'll give an example. One child started holding neck and head at 6 months. He should have done it at 3 months. So DQ was 50%. Okay. Now he started sitting at 1.5 years. Now, normally he should have sat by 7-8 months. 50% would have been 14-16 months, but it was 18 months. So now his DQ is going down. So we would call it a progressive disorder. So static and progressive is known by static DQ and a progressively worsening DQ, not by not attaining milestone. You get the point. Now here is the example I gave you where child did start sitting, but the DQ was 40%. And then when it came to standing, he stood at 3 years. The DQ was 30%, which means he has a progressive disorder. Now to know that, we must depend on the mother's history, what age the major milestones are attained. Without that correct, we won't know. But one thing is certain, this child has not lost milestones, that we are sure. So likely it must be a static disorder, but better idea would have come with comparing every milestone at different ages, at 3, 6, 9, 12 months, or at 1, 2, 3, 4, 5 years, and convince that, oh, this is static. You get the point. But I like the way you made a clear point that contractures will come in the way of motor milestones, which is not neurological. So we will depend more on social adaptive language because they are independent of contractures. And therefore, sometimes a static lesion where the milestone should go on attaining do not attain because of severe contracture and looks like a progressive disorder, but on all other domains, the static disorder is clear. So let's take it for granted that this was a static disorder, and therefore the pathology is one-time damage, like mechanical, like whatever, physical damage due to what we don't know as yet. So now we have a pathology, one-time damage to the entire motor cortex on both sides, giving rise to upper motor neuron lesion. So we got a pathology, we got anatomy. Now we come to etiology. I have already said that this child doesn't have a significant birth asphyxia, but the developmental delay is quite severe, proportionately severe. I'll give you an example to think. Suppose a 10-year-old child, while playing on the ground, he was playing football, he fell down and had a severe fracture. Okay, what do you think? He just fell down like anybody falls down. Okay, but he developed a severe fracture. What does that mean to you? He should not have developed fracture. He's a sportsman and he just slipped a little. So what I'm trying to say is that his trauma was so mild, but the effect of trauma was so big, disproportionate. What do you call it as?
Pathological fracture.
Very good.
Logical fracture.
So you call it a pathological fracture. So this child must be having some more pathology besides so-called birth asphyxia, which we have already ruled it out. Okay. But the story also continues with difficulty in feeding. Okay. So my next question to you is, what other etiologies may disturb the brain function at birth besides hypoxic ischemic encephalopathy or birth asphyxia, which are the other conditions which can affect the newborn and cause such a damage?
Hyperbilirubinemia.
All right.
Congenital abnormalities of the brain.
Very good. Congenital abnormalities. Excellent. What else?
The preterm delivery.
Very good. So preterm babies may have a lot many problems. Besides the hypoxia, they could have polycythemia. They could have hypoglycemia. So they could be hypothermic. They could have intraventricular hemorrhage because of fragile blood vessels of a preterm. But this was full term. So of all these, hypoglycemia is often hidden because if hypoglycemia was not severe, it may not have caused a seizure or a convulsion or a drowsiness, but would have just damaged the baby. So we keep that in mind that there must be some more factors, not just birth asphyxia. Probably birth asphyxia was not there. So you said two factors which can go hidden: congenital malformations in the brain and hypoglycemia at birth. Now, which baby at birth is likely to get hypoglycemia?
Infant of diabetic mother.
Diabetic
Excellent. Oh, you know so much. You're so good. Okay, preterm baby and infant of a diabetic mother. So this baby was not one of them. So possibly not. But suppose this baby could not feed initially and was not given supplements, IV or tube feeding, this baby could have had hypoglycemia. We don't know. We'll keep in mind. So we have two hidden problems. Another thing that disturbs the baby's brain at birth is hyperbilirubinemia.
Yes.
And this baby had some jaundice, right? Or no? We don't know. No.
There was no history of neonatal jaundice.
Okay, but neonatal jaundice is common, even physiological, right?
Yes, sir.
You won't know. So my question to you is, which area of the brain are damaged by increased bilirubin?
Basal ganglia.
Excellent,
Basal
excellent.
ganglia.
So it's a basal ganglia and not just this. Well, this also may be involved. So we don't have hyperbilirubinemia. We may have a hypoglycemia. We may have a congenital malformation. Now, one more thing. Madhumitha, you gave me a history that in the first trimester, this mother had 10 days of fever, right?
Yes, sir.
Now, do you think this baby developed a congenital infection?
No, sir. Because there was no other associated symptoms of any torch infections, sir.
So see, all these infections are not easy to diagnose only by the history. But we know that mother had 10 days of fever. Okay. So something went wrong with the mother in first trimester. So the fetus could have been infected, and now this fetus is coming out with a severe damage to the brain. And on examination, we might find hepatosplenomegaly, some eye signs, okay, some hematological problem, meaning thereby that this is a disseminated congenital infection. But many times the congenital infection which starts very early in fetal life may even disappear, die out, but leave behind the damage. So tell me one good reason why this may not be a congenital infection. And the reason is when they are infected very early in life in the first trimester, they are likely to suffer severe damage like this child has, but the almost all of them have a low birth weight. They have an IUGR. This baby had a normal birth weight. So very unlikely that this baby has any congenital infection. So we take away that. And of course, there are no drugs in the mother during pregnancy. There is no radiation. So the antenatal problems that cause damage to the baby's brain are drugs, radiation, congenital infection, congenital malformation, and a chromosomal abnormality. Now, can you guess a chromosomal abnormality on history?
Sir,
Yeah, go ahead.
Sir, sir, previous history of abortions,
All
first
right.
trimester abortions,
All right.
and a previous sibling affected with some chromosomal anomalies, and any other family members having the disease, sir.
All right. Now, let
So
me
even
say,
recurrent infections,
all right. Okay. Let me give you a clue.
respiratory.
Okay. That if we are considering chromosomal disorders, tell me the commonest chromosomal disorder may be Down syndrome, Mongolism.
Increasing maternal age.
Ah, that's right.
Yes,
Age of the mother and age of the father.
father, right, sir.
Okay. So it may give you some idea, right? It's not necessarily that every mother at that age produces, but what we are trying to judge is, can we collect more and more information to suspect most of the chromosomal disorders have other defects too, like maybe a heart defect. So there could be a symptoms of a heart disease or abdominal distension. Okay, so I think we may guess whether one could be meeting a chromosomal disorder by this. There could be a consanguinity talking about a familial illnesses. So this is the way we guess for that. So far, we have come to a conclusion on the history that this child's anatomy is bilateral extensive involvement of motor cortex. Pathology is a one-time damage, okay, which is not active just now, but a damage. So healed lesion. So we have no inflammation or infiltration or whatever. And etiology is possibly multifactorial, in which birth asphyxia is not the cause or may have a very insignificant contribution, but there could be other factors. One of the prominent one could be maybe congenital malformation or any such electrolyting. Now, going further on this guesswork, hypoglycemia at birth usually involves vision as the most important part of involvement. So if this child was not able to recognize mother, not able to follow light, and there was a visual disturbances, then we would have straight away claimed to be considering hypoglycemia, though it could involve all parts of the brain. Plus, there has been never a seizure or a convulsion, and therefore, if at all this was not a significant low level of blood glucose, it could have been one more factor. That's why I said that in your history, not a single factor can be blamed, so there must be multifactorial. So we will say of multifactorial etiology. We can't make out. All right. Any questions so far on how to analyze the history? Or you're all clear on that? Very good.
Yes.
Okay. Let's Madhumita share the slides and tell us the examination findings.
Okay, sir.
Sir, a
Yeah.
few doubts have been asked in the chat, sir.
Yes.
Can you read it out?
Yes, please.
So they've asked, is there a role of Apgar score to diagnose birth asphyxia?
Yes, but Apgar score low only means that there has been some problem in initiation of breathing. That's it. Okay. It doesn't tell you birth asphyxia only, but it just tells you what is the level of the brain function at that time. Again, Apgar score at 1 minute, 5 minutes, and 10 minutes might give you an idea how we go by that. So, Apgar score only helps us to decide how aggressive our intervention should be, more than finding the cause for it. Right? Yeah.
And they've asked, can we consider inborn error of metabolism as...
Yes. See, we started discussing that this is likely to be a static disorder, and inborn error of metabolism manifesting very early is a progressive disorder. That's number one. But most important part of inborn error of metabolism is a baby is normal at birth. And what is the inborn error of metabolism? When the baby starts feeding and milk gets into the system, to which there is a metabolic error, so abnormal metabolites accumulate and disturb the brain function or liver function. So the story starts after the feeding. But till then, the baby is absolutely all right. This baby was never well, even right from birth. So typical inborn error of metabolism has a very normal health status at birth. And then depending on how early the symptoms come, it means the metabolic error is very severe. For example, if the child was all right at birth and at the end of 48 hours of having taken a little breast milk, till then it's only a small colostrum. When the breast milk starts going in, the manifestations come up, and the classical manifestations are acute onset vomiting with encephalopathy, seizure, drowsiness, etc. But same situation may occur even late in the course of child's development if the metabolic error was not so severe and only mild or moderate, and the same story will occur at 6 months or even 1 year. So inborn error of metabolism can come at any age depending on severity, but child is essentially normal at birth and it's a progressive deterioration. So we are not considering that in this child. All right. Any other things on the chat?
No, sir. That's all.
Fine.
Sir. Thank you.
So Madhumata, go ahead. Go ahead.
Okay, sir. Summary of history. A 5-year-old first-order male child born out of non-consanguineous marriage belonging to lower middle class consumes an adequate diet sorry sir, there is a repetition, with chief complaints of not attaining age-appropriate milestones since 1 year, with history of birth asphyxia and NICU admission for 3 days, with stiffness of all 4 limbs, and he is a known case of global developmental delay with developmental age of 14 months.
Very good. Again, just to make you fine tune, because you are worth a medal. You are not just worth for passing. Okay. After all, almost everybody who enters the medical college leaves with MBBS degrees. Nothing great about it. But you look to be at a higher level. So I must take you even to that height. Okay. How would you be summarizing ABC? Accurate, brief, and clear. How could I have made you brief? You could have said 5-year-old child, healthy child. Okay, healthy child tells you that he is consuming all diet well and all. Okay, so 5-year-old healthy child with no significant family history. So I'm out of all that. Okay, had a developmental delay which was static, more in the motor domain than social, cognitive, or language, and it was static, probably a result of a multifactorial factor. Some of them could be birth asphyxia, hypoglycemia, or a congenital malformation, right? So that tells you that. Now, to call it a cerebral palsy, okay, what are the prerequisites to call it a cerebral palsy?
Sir, there is no degeneration of the attained milestone.
All right, so it is static. All
Yes, sir.
right. So
And
cerebral palsy, yes, go ahead, go ahead, go ahead. So cerebral palsy
Posture and
has,
movement is affected.
yes, yes.
It is
So,
non-progressive, one-time event, static event, which
very
is
good.
the cause is maybe prenatal, perinatal, or postnatal.
Very good. Add two more things which are important. One is that it's a static motor. Okay. So, so static motor encephalopathy. Okay. In
Yes.
a damage in a growing brain. Okay. So damage in a growing brain. Now tell me, how long does the brain grow in life, postnatal life?
So first 2
2
years,
years.
Excellent, excellent. By the end of 2 years, 90-95% of brain growth is over. So some authors take it up 3 years, some 2 years. But in a definition, static, non-progressive encephalopathy with motor involvement in a growing brain. Okay, with or without many other things like delay in other cognition or a social adaptive language, maybe vision, hearing, seizure, all that is yes or no. But what is the correct definition? Minimum motor encephalopathy, growing brain, static. Okay, with many other things or even without. So let's see whether this is going to be one of those. But so far, we only know that there is no significant brain damage on history, and we are not sure where we are leading, right? Let's see the examination findings.
General examination, the baby is conscious, hydration is fair, and the child was in supine position with legs crossed and responded to verbal commands by his mother. On pull to sit, there was tightening of muscles seen and moderate pallor present, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, and no pedal or sacral edema. Vitals, pulse rate 100 per minute, normal in rate, rhythm, volume, and character. No radioradial and no radiofemoral delay. All peripheral pulses felt. Respiratory rate 30 per minute, predominantly abdominothoracic in type, and blood pressure 90/60 millimeters of mercury, measured in the left upper arm in supine position, and temperature. The child was afebrile, and in the airway there was no pooling of secretions. And anthropometry, weight, sir, can I say in detail, sir, or?
Yeah, so you could say that all are proportionate, right? But tell me
Yes, sir.
head circumference. Tell me head circumference.
The head circumference was normal, sir, at 58
Oh,
centimeters.
now that is the point. You never diagnose cerebral palsy with normal head circumference as a rule. It could be an
Okay, sir.
exception. We will discuss that at the end. But the minimum finding is a microcephaly. And this child doesn't have that. So this does not satisfy a diagnosis of a cerebral palsy. And why should a brain be, a head circumference be small?
Because there is major insult, sir, so the brain has not attained the age appropriate growth, sir.
Correct. So what you are trying to say is that if the insult occurs very close to birth, where the brain growth is very fast, and
Yes, sir.
thereafter the brain growth almost does not continue at the same rate, you are left behind with a small brain, and because of small brain, the small skull. Skull doesn't grow because the brain is not growing. So for a CP, microcephaly is a must. And this child does not satisfy that. So we will look at it later on that. Fine. So, so far we have come out of calling it as a cerebral palsy just by that. Okay, go ahead.
Yes, sir.
Next.
It's a graph for showing the weight for height. The child is on the at the
Fine.
-2 standard deviation and head to toe examination. Head normal in size and anterior and posterior fontanelle closed. There is no abnormal head movements. Face, no dysmorphic facies. Eyes, no telangiectasia. Epicanthus absent. No ptosis, enophthalmos and corneal opacity. Neck normal. Ears normal, no discharge. And oral cavity, no cleft palate, no dental caries. Chest normal. Extremities, no polydactyly and syndactyly. Palms and soles normal. And the contractions were present in both feet. And genitalia was normal. Back normal, no tuft of hair, no bed sores seen.
Go ahead.
CNS examination, the child was conscious and active, and cranial nerve examination, first cranial nerve could not be tested, and second,
all normal.
Yes, sir.
All normal.
Yes, sir.
Fine. So let's go further.
In motor system, wasting of muscles was seen in both upper limbs and lower limbs, sir.
Wait, Madhumitha, wait. Wasting is high.
Yes,
Wasting
sir.
is lower motor neuron. And we are talking about upper motor neuron. Ah, very good. But why not lower motor neuron?
In flaccid, sir, but here the history here the muscles are stiff.
Fine. So there is a spasticity. All right. Okay, go ahead. So cranial nerves are normal. Motor system. Go ahead.
This is a measurement, sir, and tone on inspection stiff. Upper limbs and lower limbs were stiff. On palpation, it was rigid, sir, and the resistance to passive movement was increased in both upper limbs and lower limbs, and the range of movements was decreased in all four limbs. So, so I came to conclusion that the extremities are spastic.
Now tell me, why do you use the word spasticity? I would use the word rigidity.
If both extensor and flexor are involved, it's called as rigidity, sir. If one group of muscles is involved, it's called as spasticity.
So how do you know which group of muscles are involved?
Rate dependent.
In other words, I am asking you, what is the clinical differentiation between a clasp knife spasticity and a rigidity?
Velocity dependent.
Excellent.
Uniform resistance.
Excellent. Velocity dependent. And what happens if in a child of a extrapyramidal basal ganglia disease where there is a rigidity, whatever, lead pipe or whatever, it doesn't make a difference.
Oh, yes.
Then if you move it fast, what happens? What happens?
It stays the same.
Yeah, it releases the tone. Whereas in a clasp knife, it is persistent. Excellent. So velocity dependent will be called spasticity. Do you know any third type of increased tone? Spasticity, rigidity, any third type?
Dystonia.
Excellent. Dystonia is the third type. Now, you describe what is dystonia to me. We said rigidity and spasticity. We are clear. What is dystonia?
So dystonia is abnormal posturing of the body because of improper contraction of the different groups of muscles.
All right. Partly right. So there may not be contraction. So the dystonia is increased tone with twisting. Okay, twisting. That's so increased tone with twisting. That's what you said, right? Abnormal posture. Okay.
Yes.
And many times the mild dystonia may not be visible on inspection, but when you stimulate the child, he does that. That is dystonia, and we will look for it carefully on examination whether, see, the point is in a given child neurologically, all kinds of tone may be present in a single child in a disease. So much so that there could be a combination of hypotonia hypertonia, rigidity, spasticity, dystonia, everything, depending on which are all structures that are involved. So when you demonstrate spasticity in an examination, also make sure that there is no accompanying rigidity or dystonia or anything else, right? Very good. Go ahead.
Yes, sir. And the best observed power in upper limb and lower limb is 3/5, and the child is able to lift the head, and the child is able to move in bed.
Very good.
So the
Now, tell me, Madhumitha,
Yes, sir.
is 3/5 normal?
Sir, 3/5 means the child is able to move against gravity, sir. It's not normal.
So he has got a loss of power. That's not a cerebral palsy, because cerebral palsy is a tone and posture abnormality. Tone
Yes,
and
sir.
posture. But here is a loss of power. So point is, generally we end up saying it's 3/5 because it's sometimes difficult to decide
Yes, sir.
whether it's 4/5 or 5/5. 5/5 is impossible in a child because he's not going to cooperate against your resistance. But he may be able to show you if a child could be walking, then you could say he has a normal power. We are interested in knowing whether there is a loss of significant power. Therefore, in pediatric practice, many times you say it's more than 3/5. Okay, it doesn't mean there is a loss of power. It only means inability to further specify whether it's 4/5 or 5/5, right? Okay, go ahead. What about reflexes?
The conjunctival and abdominal reflex was present, and plantar reflex was extensor. Babinski sign is seen, sir. And all the deep tendon reflexes were exaggerated, sir.
Okay, now you know that plantar could be flexor or extensor, right? Could it be
Yes, sir.
absent, plantar absent?
Sir, if sir, in conditions where there is thick sole and
So what is plantar absent? We know plantar flexor, plantar extensor. When the sensory system there is involved or the great toe is paralyzed, we get plantar absent. So just keep a note, sometimes plantar is absent. After all, what do you need? You need a stroke. So there has to be a sensory system and there has to be an effect with a motor system. So it's an arc. If any part of the arc is involved, you don't get plantar at all. And so plantar may be flexor, extensor, or even absent. Okay, so this is an extensor plantar. All right, go ahead. And the rest of the thing is normal. Okay. You have said autonomic nervous system could not be examined, is it? Not done.
yes, sir.
So how do you examine autonomic nervous system?
Sir, postural hypotension. We have to ask the child to stand up after lying down by just near the wall, sir, and we have to look the blood pressure in both the when.
All right, but what happens? This child if the child cannot stand, then you can't test.
Yes, sir.
So then, what are the other signs of? Can you examine autonomic nervous system in an unconscious child?
So pupil reflexor in
which may be related to second or third cranial nerve.
Okay, sir.
So few signs which you need to look carefully. They are not common. One is a Palmer erythema. Palmer erythema is a sign of an autonomic nervous dysfunction. Okay. And the second sign is because of the vasomotor dysfunction, you can write the child's name by your nail on his skin. You can almost do that because, yes. So these are the signs of autonomic nervous system, besides, of course, changing heart rate, respiratory rate, temperature, blood pressure, all that. But in an unconscious child is so that's fine. Fine. Other systems are normal, right?
Yes, sir.
Fine. So now you have a problem. A head circumference is not small. So we are not going to call this as a cerebral palsy, but the exception exists. Point is, a static disorder where the DQ is apparently static may look similar to a very slowly progressive disorder. Imagine some progressive disorder is going to take 10 years to progress. Then progress is so slow that it appears to be static. So cerebral palsy with a large head or a normal head is a suspicion and must be confirmed. The exceptions are there, but the rule is microcephaly. So now, how do you confirm that? How do you confirm a cerebral palsy? You want to do a lumbar puncture?
Neuroimaging, sir.
CSF? What about CSF? Would you do a CSF?
So only in meningitis in case of.
Very good. So one indication of lumbar puncture is intracranial infection. Any other indications of CSF? CSF can be tested for varieties of other things like the lactate, for example. Inborn error of metabolism could be tested. Then CSF could be tested for some antibodies or antigen. CSF for culture, of course. So this child doesn't deserve to do a CSF. And you said imaging. What
Yes,
imaging? X-ray?
MRI.
MRI. Why not CT scan? So when do you do a CT scan in a neurological disease and when do you do MRI scan?
Sir, if we suspect any major congenital anomaly, we can go with CT, sir.
All right.
Atrophy of cerebral hemisphere.
All right. Good. So in general, MRI.
Neuromigrational disorders for.
Excellent. MRI is able to pick up a subset of a cell. For example, cortex differentiation between white and gray matter is possible with MRI, but not by CT. So the small differences in the same site can be picked up by MRI well. Another thing is CT scan is not a good imaging modality for a posterior cranial fossa. So anything posterior cranial fossa, you would like to do an MRI. And so in this child, because we wanted to see many more details of cortex, whether it's the white matter, gray matter, any other abnormality. For example, you rightly said, is there a migration abnormality? CT will not show. We will have to do an MRI. So we'll do an MRI and do that. Good. I think we will just end up by asking you, how are you going to manage this child?
Sir, it is a multidisciplinary approach, sir.
Good.
A pediatrician should play a main role in that. And physiotherapy can be given for the contracture, sir, and speech therapy for improving the milestone, and also we have to educate the parents and
good. I think you have almost summarized it very, very well. So let me ask you a few things now.
Yes,
you said this child has contractures. Okay. Do you know two types of contractures? One is dynamic contracture and another is static contracture. What do you mean by static and dynamic? If it's a static contracture, physiotherapy is useless because the joint cannot move at all. If it's a dynamic contracture, physiotherapy has a role. And how do you know whether it's a dynamic or static? Normally what you do is that when suppose you are looking at a knee joint, okay, I'll show you with my hand. Okay, I am looking at my wrist, whether the contracture is dynamic or static. So the examiner pushes my hand and with a jerk, if he is able to do that, then the joint is movable, contracture is dynamic. But further, I press hard and move further. This is by physiotherapy is known as R1 and R2 levels. R1 is first immediate thrust. So here is my stiff wrist. Okay, I give a thrust, that is my R1. Okay, and then I push slowly further, that is my R2. If R1 and R2 are same, it is dynamic. What do you mean by that? This is the wrist, R1, and I push further, it doesn't go. That means R1 and R2 are same, it's static. And if this is R1 and then now if R1 and R2 are different, it's a dynamic contracture. Try your physiotherapy best. And if it is already a static contracture, then don't waste time in doing physiotherapy. Get to some other modalities like any surgical correction or maybe, so we'll not go much in detail. There's no need to do that. But it's a good idea to tell an examiner whether it is a static or a dynamic contracture. So that's one. You said physiotherapy. Does physiotherapy help in improvement of power? It does not.
No, sir.
It only takes care of contractures. Okay. Then what about occupational therapy? Have you heard the term occupational
Yes,
therapy?
sir.
What is occupational therapy?
Sir, the child should, because of this, the child should not be separate from the community, sir. It should be a part of community. So we should teach the child for self-employment, and we should normalize the child as much as possible, sir.
Fine. So occupational therapy, but what is the occupation of this child? There is no occupation, no.
Yes, sir.
So occupational therapy makes the child self-dependent, like feeding by himself, by buttoning the shirt, putting on the shoes. Oh, this is all occupational therapy to become self-sufficient as much as possible. Last thing, you said speech therapy. Who gets speech therapy? Everybody who cannot talk gets speech therapy?
No, sir.
No.
The
Go ahead.
pathways should be good. For this R3, so some.
Yeah.
No. So the pathways should be good, sir, so that if we train the child can speak, sir.
Okay. Difference between language and speech. Language and speech are both same.
No, sir. Language is a communication. It's the
Excellent.
speech is for articulation, sir. Language is from inner side.
Very good. So language is of two types: receptive language and expressive language. Now, receptive language means he understands what I am talking. That is receptive language. And what is expressive language? He is able to express. But expressive language is of two types. One by gestures. One by gesture. Okay. Yes, the child will say, oh, I want that. So here's a language, but not verbal. So speech is a verbal language. And only if the motor part is involved, that means the receptive speech is fine, receptive language is fine, and the non-verbal language is also there, then only the speech therapy helps. Suppose he has no receptive language, how can you train him to produce an expressive language? Therefore, in a normal child's language development, the first part is receptive language. And a child of 1 month is able to receive language. How do you know that? When he's crying and the mother sings a song, or mother says, "Oh, you are a good boy," the baby starts keeping quiet. Receptive language. Okay, receptive language starts so early, but the Baba Mama comes much later. And before that, the non-verbal expressive language comes. He looks at something, that is expressive language. So the speech therapy is ideal when only motor part is involved, but the receptive language is right. All right, good. I think we should stop at this time. We are 7:15 and we have had a reasonably good discussion. I must admit one thing, that your batches are excellent, which means two things. You yourself are so good, and you are also guided by good teachers. Okay, but same teachers guide everybody, but not everybody is good. So as a teacher, I don't take a credit because one of my students is doing very well, because I'm selfish. I don't want to take a blame if somebody is not doing well. Okay, so credit is all yours. I am amazed to see how much you know. Okay, you can compete with my postgraduates. And at Sion Hospital, where we take PG clinics, Kunj may know that the previous
sir.
batch was even sometimes better than my postgraduates. Better than my postgraduates. Okay, so I can see the present generation is far too ahead. Only thing is the path should be proper, which means the clinical bedside medicine and the basics must be strong. Then comes the CT scan, MRI, spectroscopy, okay, all that. But the basics should be strong. And I only know basics. I don't know high-fi medicine. So I teach only basics. Okay, good. Thank you very much
Thank you,
for
sir.
everybody's
Thank you, sir.
participation.
Thank you, sir.
It was
Thank you.
Madhumita very good. Like last time, she also did so well. Okay, I am extremely happy that your batch of students are so well. Well done. Thank you very much.
Thank
Thank
you,
you.
sir.
Good
Thank
job.
you,
Good
sir.
job.
Thank you.
Very
Thank you,
good.
sir. Learned a lot from you, sir. Thank you, sir.
Thank you. Thank you.
The discussion was very useful for us, sir. Thank you so much. And thank you, Professor Y.K. Amdekar, sir, for teaching and guiding us. We are ever grateful to you. Need your blessings, guidance, and support throughout, sir. And it was a great effort by the presenter, Ms.Madhumitha. We could learn a lot because of your well-prepared presentation. Thank you, Ms. Madhumitha. And we also thank Avantika Sood from BMC Research Institute, Bengaluru, and Melvin Mebin from Ashan Institute of Medical Science, Hassan, and Kunj LTMMC from Mumbai for the active participation. We also thank all the participants who are enthusiastically answering. Thank you, one and all. Thank you, sir.
Thank you very much. Good night.
Thanks.
Thank you, Vaitami, for giving me the opportunity. Thank you.
Thank you, Madhumita.
You.